I'm going to talk today about genetics and how they can really speak towards future therapy and glaucoma management by clinicians. And so I think sometimes it's easier just to focus on your goals before you talk about how you're doing reaching them. And this pathway here that I've drawn up there is what I think about when I think about studying genetics in my lab. Is what I really want to do is I'm hoping we can move towards preventing vision loss by developing new treatments by doing genetic studies. That's what our big goal is. But I think we can also have some pretty big successes by studying by studying genes, finding genetic tests, and then we can make tools to help our clinicians do a better job of diagnosing and predicting how a patient's course will go, maybe even how they'll respond to certain therapies or surgeries. Later, at least some of the talks later today will talk about some of these other treatments will be developed using animal models, using stem cells, gene therapy, and such. I'm going to talk a little bit about transgenic animals as they relate to genetic study of glaucoma. I want to spend a little bit of time reviewing basic ideas about genetics and glaucoma. I think everyone knows as a clinician that glaucoma is a pretty general descriptive term, and that it really refers to lots of different diseases. That's especially true when you're thinking about glaucoma as a genetic disease, is that there are multiple causes. And because of that, it's important to think about what kinds of genetic influences do you expect to find when you study glaucoma. And I like to group it into two different groups. There's one group of glaucoma that has a very clear genetic cause, where a single gene is responsible for most of the reason why some patients get glaucoma. These kinds of glaucoma are fairly rare. They're very familial. Mostly for adult onset glaucoma, they're autosomal dominantly inherited. Because of this, the mutations in these genes are really only seen in patients, and they're not really ever seen in unaffected patients. So this is a key feature of this portion of glaucoma genetics. Probably responsible for maybe 1 in 20 cases. The rest of the glaucoma that has genetic influence is much more complicated, and it's probably caused by the actions of many genes working together in concert. And no single genetic risk factor of this type can cause disease on its own. Because of this, you really expect to see these kinds of so-called risk factors very commonly in people who don't have glaucoma. It's just that they're statistically more frequent in those that develop glaucoma. So they're more common in patients than controls, but really commonly seen in controls. Several genes that primarily cause disease on their own have been discovered, and I've put 3 of them up on the list here, because these are the ones that have the most consensus. Additionally, some of the risk factors that have been discovered are shown below, but for the rest of my time, I want to focus on these genes, so-called single gene forms of glaucoma, because they're a little easier to study, and I think there are more practical uses for the knowledge that we have in this area. So back to the flowchart that I showed earlier is throughout the rest of my time, I'm going to pop up these little yellow boxes to kind of help remind us where we are in this flowchart when I'm talking about other parts of glaucoma genetics. As far as genetic testing goes, for the 3 Mendelian genes, there's already genetic testing available for myocilin and optineurin, and I think probably one of the most useful things for clinicians or anyone interested in genetic testing is a website that the NIH puts out called genetest.org. It's a really neat website. It has some reviews made by experts written in plain English, and it also tells you where all the labs are that are doing testing and you can look at links and figure out what the cost and turnaround and methods are. So this is a great resource. Now, why would you do genetic testing? I think one reason is that when you do find some of your patients have mutations, you can know what to expect for their presentation of disease. This is a table from a paper that we reported in New England Journal that has different phenotypes, different clinical presentations for several different mutations in myocilin. some of the patients with mycilin mutations, like the group highlighted in red on this diagram, had a very early onset of disease, in this case an average age of 20, and very high intraocular pressure on presentation in the 40s, 44 millimeters of mercury. And this can be helpful to know what to expect as far as treatment. And many of these patients also were known to respond very poorly to medical treatments and needed to move to trabeculectomy very quickly. And that can help you plan management. The features of a mycilin-related are very much glaucoma. Very high intraocular pressure, early onset of disease, and strong family history. The testing can be very useful in these cases. With juvenile glaucoma, there's a high rate of positive testing, and with primary open-angle glaucoma, it's quite a bit lower. So when would you decide to do mycilin testing? In my opinion, the more a patient is like a juvenile glaucoma patient, the more likely it is to be useful. So in many cases, it's useful to test patients that have juvenile glaucoma for mycilin, and I think family members of those known to carry mycilin mutations are also worthwhile in studying for mycilin mutations. But at present, since the unselected primary open-angle glaucoma patient rate of having mutations in mycilin is low, 3 to 4%, it's probably not worth it to test all of your patients for mycilin. Well, what have we learned about mechanism of disease and about how to treat patients from our studies of mycilin genetics? A number of studies have shown that the primary defect in patients that have mycilin mutations is a problem with the protein encoded by mycilin. It seems to fold improperly in trabecular meshwork cells and accumulate. This leads, we think, to loss of trabecular meshwork cells, reduction in outflow, and elevated intraocular pressure. So studying some transgenic mice, Dr. Sheffield's lab at Iowa has shown that molecules that can help mycilin protein fold better can reduce interocular pressure in the mice and prevent them from having nerve damage. So this is really exciting, is that this molecule that they studied, it's called PBA, or phenylbutyrate, may have some real potential for treating patients with mycilin-related glaucoma and perhaps all primary open-angle glaucoma. In future human trials will really be exciting to see where that goes. For the next few minutes that I have to talk, I want to talk a little bit about another gene, TBK1, or tank binding kinase 1, that is an important gene in the pathophysiology of normal tension glaucoma. My lab studied TBK1 for the last couple years, and we've shown that mutations in this gene are responsible for between 0.5% and 1.5% of normal tension glaucoma patients. We've seen this in patients from America, patients from Japan, and also some select African American patients. So maybe one in 100 patients may have a mutation in this gene. But as I'll show you, I think there's some reason to be excited about this discovery, not just because of its prevalence. The patients that have TBK1 glaucoma are pretty typical normal tension glaucoma patients, except for their severity maybe a little bit more pronounced. The patients get disease at an early age, and they seem to have a very rapid progression. They also have notably thin corneas, as many other normal tension glaucoma patients do. Well, what does TBK1, what does that gene do? It encodes a protein that puts phosphate groups on other proteins, and the thing that's most remarkable is that there seems to be a pathway coming together that's very important in normal tension glaucoma. Several genes have been linked to the same pathway in the pathophysiology of normal tension glaucoma. Dr. Safarazi in Connecticut many years ago showed that the optineurin gene is important in normal tension glaucoma, and a Japanese group from Gifu in Yokohama showed that the toll-like receptor 4 may be a risk factor for normal tension glaucoma. All of these genes encode proteins that are involved in a process called autophagy. This is a process where abnormal protein accumulations and in some cases pathogens are marked for destruction and cleared from cells. And so it seems like defects in these genes may be really important in how normal tension glaucoma develops. And I think even though the percentage of cases caused by mutations in these genes may be low, it might help us understand the process. So in my lab, we made just recently some transgenic mice. And these mice have the exact same genetic defect as our patients that have glaucoma related to TBK1 mutation. That is, they have an extra copy of the TBK1 gene. And we studied the mice much as clinicians examine their patients. We measured their intraocular pressure, and in this case, they having an extra dose of the TBK1 gene caused no elevation in intraocular pressure. They remain a good model for normal tension glaucoma. We also studied their optic nerves, not by looking for cup-to-disc ratio. That's pretty hard to do in a mouse. But we're able to study their retinas using histology, and we counted the retinal ganglion cells. We've been studying a large cohort of these TBK1 mice, and we've been comparing 25 transgenic or mutant mice and 25 controls at several time points. The first time point is 7 months, and I've shown you that the data here that they seem to have about a 10% reduction in retinal ganglion cells that's highly significant. So we think these mice develop a neuropathy that we believe is a normal tension glaucomatous optic neuropathy. This is very exciting for a number of reasons. Mostly, I think it validates our studies of the human gene, is that the defects we see in our patients are really proven to cause disease based on these mouse studies. But the other thing that's very exciting is that this provides us a model to study the process by which the optic nerve can be damaged in the absence of elevated intraocular pressure, and gives us an opportunity to develop interventions that we can test in the mice and see if they'll be good options for our patients. So TBK1, as I mentioned, is a kinase, and there are multiple kinase molecule inhibitors that are known to inhibit this gene product. And we're very excited to see if we can treat these mice, cure their optic neuropathy, prevent them from losing retinal ganglion cells, and perhaps come up with some new therapies that'll help our normal tension glaucoma patients in the clinic. So just to summarize, I think there's no question that the genetics of glaucoma is very complicated. Other talks at the meeting have discussed the genetic risk factors that haven't been discovered yet that lead to complex forms of glaucoma. I think there's much that we've already learned from the simple forms of genetic glaucoma, and I'm really optimistic that in the next 5 to 10 years we'll likely have new therapies other than eye pressure lowering drugs to treat our patients. Thank you.